Good morning, everyone. I'll be presenting on behalf of Medicine 2. This is regarding Mr. R, a 55-year-old manager in a plywood company currently residing in Kerala. He presented with low-grade fevers and headaches for the past 2 months, associated with mild cough with expectoration. However, in the last 10 days, he was noted to suffer from severe fatigue, and he had increased difficulty recalling and increased forgetfulness. He was unable to remember where he was or where was unable to remember his own recognize his own family members. In the last week, he also presented with imbalance in swaying while walking, due to which he had 2 episodes of fall with no subsequent head injury or loss of consciousness. In the last 2 days, he was also noted to have complained of experiencing double vision intermittently. There was no history of seizures or loss of consciousness. There was no episodes of delirium. There was no projectile vomiting. There was no history of numbing, tingness, or paresthesias. Past history, he is not known to have any other comorbidities. He was not also on any chronic medications for chronic pain, and he is a known case of pulmonary TB, which was diagnosed and treated when he was an adolescent. Personal history wise, he consumes a predominantly vegetarian diet, but once a week consumes fish cooked in outside restaurants. Other than that, he takes most of his meals at home. There is no history of recent travel, and there's no history of consuming exotic animals or freshwater snails. There's not a smoker or ethanol consumer. On examination, he was vitally stable. Other system examination was normal. CNS examination showed that he was. CNS examination showed that he was oriented to person but not oriented to time or place. Speech and fluency and repetition were normal, but recall he was unable to recall. His mini mental status examination showed it was 11 by 13. Cranial nerve examinations, second cranial nerve, pupils are bilaterally reactive to light. Fundus examination showed a papal edema. Visual acuity was also impaired. Extraocular movements were not full. There was a right eye ptosis and left eye abduction palsy. Other than that, other cranial nerve examinations were normal. Motor system, his bulk and tone was normal. Reflexes were 2+ bilaterally. Planters alone, there was right-sided flexor plantar and left extensor plantar. There were some cerebellar signs with pass pointing and dystokinesia. Due to his severe swaying, we were unable to perform tandem walking. Meningeal signs, there was neck stiffness at presentation with Kernick signs was positive. So the differentials we considered was that of a syndrome components of a chronic meningoencephalitis. The infectious causes we considered were a probable tuberculous meningitis, a brain abscess, melioidosis, neurosyphilis, or fungal causes such as histoplasmosis or cryptococcosis. We were unaware of a seropositive status, so diseases like toxoplasmosis were also considered. Other than that, non-infective causes such as CNS vasculitis, neurosarcoidosis were also considered. Neoplastic causes such as primary CNS lymphoma can also present with a chronic meningoencephalitic syndrome. So preliminary investigations showed a elevated total count of 19,200. But with a peripheral eosinophilia of 32. Other investigations showed a mild transaminitis and mild anemia. Other than that, all his routine investigations were not revealing of any pathology. CSF studies were done after an MRI. CSF appearance was xanthochromic. Glucose was low and protein was also elevated. He had elevated cell counts in the CSF of 920 with at least a 10% of eosinophilia in the CSF. So I'd like to talk about eosinophilic meningitis today. Eosinophilic meningitis is defined as the presence of more than 10 eosinophils per millimeter cube in CSF, or eosinophils accounting for more than 10% of CSF leukocytes. In light of this, we expanded our differentials to include causes of eosinophilic meningitis as well. So the main primary causes of eosinophilic meningitis are nematode infestations, primarily by Angiostrongylis cantonensis, Nathostoma spinogerum, and Balis caris. Other tapeworms and roundworms are also known to cause eosinophilic meningitis. Non-infectious causes such as CNS lymphoma were also considered, however, they were lower down the line. While testing for causes of eosinophilic meningitis, we had tested for a qPCR for Angiostrongylis cantonensis, which had returned positive. So angiostrongyliasis, I'd like to talk about the pathogen insult. It is called the rat lungworm. It is a nematode and has a predilection to cause neurological manifestation. The definite hosts are rats. Intermediate hosts are freshwater snails, land snails, and are wanted in transmission of the disease to humans. Humans are accidental hosts, but infections doesn't necessarily have to occur in an immunocompromised host. They can occur in an immunocompetent host as well. The environment, they live in live in freshwater snails, and they are found prevalently in water contaminated with freshwater snails. It's studied that even the snail's mucin is known to transmit this infection. The time period usually for the neurological manifestations to occur typically takes around 2 to 35 days. So humans get infected by eating produce contaminated by the water harboring the intermediate host, or eating the raw meat of definitive hosts such as rats or monitor lizards. Drinking water can also be contaminated by freshwater snails, and keeping undercooked meat or fish which have ingested the freshwater snails can also cause an Angiostrongylis infection. So epidemiology, most cases of eosinophilic meningitis originate from Southeast Asia and the Pacific Islands. However, there has been an increasing incidence in India, and cases have been reported from many states up north and south, mostly in Delhi, Karnataka, and Kerala, and Puducherry, Telangana, and West Bengal as well. Most recently, there was a case series of eosinophilic meningitis in 2025 from Kerala, where they had seen 3 female immunocompetent middle-aged women who have been diagnosed with eosinophilic meningitis. So the clinical features, patients present with CNS manifestations typically with severe headaches, neck stiffness, photophobia, and nausea and vomiting is also present due to, and cranial nerve palsies are also present. The diagnosis of of Angiostrongylis can be because of the following. Peripheral eosinophilia can give us a clue as to whether there's a systemic parasitic infestation, but eosinophilia in the CSF is a hallmark of diagnosis of angiostrongylitis. And microscopy of the CSF is not a sensitive test, but larvae can sometimes be seen in the wet mount of CSF. However, in our patient, we could not demonstrate any larvae. Stool tests for parasites may or may not be positive. Now, quite recently, qPCR DNA-based testings are more sensitive and are currently used for definitive diagnosis. The role of imaging in angiostrongylosis is non-specific, as it can lead to many changes which include but are not limited to microabscesses or microbleeds. Sometimes there are focal linear hemorrhages showing tract-like appearances in the MRI, and acute infarcts can also happen. Our patient had some leptomeningeal enhancements in the areas of acute ischemia involving the left external capsule and midbrain, and there were some intensities in the hippocampus, which could also be due to the encephalitic syndrome itself, but also can be an infarct. There were bilateral tortuous optic nerves and mild perioptic CSF flash secondary to the raised ICP. So the treatment of angiostrongylosis the mainstay of treatment is corticosteroids. Prednisolone is usually preferred, but there have been case reports which use dexamethasone as well. They have been used to known to decrease the severity of the headaches, but the improvement in cognitive dysfunction is still unknown. Antihelminthic drugs, mainly albendazoles, other benzimidazoles such as mebendazole, treclabendazole are not preferred. They can be also added as an adjunct to treatment. However, the comparison between prednisolone plus albendazole with prednisolone alone does not confer any increased benefit. There are several case studies showing that steroids alone can decrease the severity of the headache and can improve cranial nerve dysfunction. So these studies have shown that there is marginal benefit with using albendazole along with prednisolone. However, the significance of the results are still up to debate. So the updated recommendations as per take as the updated recommendations recommend that albendazole and prednisolone be given in combination, but it's a low-grade recommendation. Back to our patient, we have therefore started our patient with corticosteroids and albendazole. Because of the neurotropic predilection of the larvae, we have also planned for a formal ophthalmologic evaluation. So the learning points in our patient would be an approach to eosinophilic meningitis and treatment of Angiostrongylis cantonensis.
Good show. One comment. When you're presenting a case, at the end of history and finding, especially neurology, you must first do anatomical localization. You presented various cranial nerve findings, motor findings. Then you must say anatomically this is localized either to one specific area. Then first you must say LMN, UMN. If you have one localization, you may say it is localized to this part of brain stem or this part of brain pons or whichever place. Or if you have multiple localized, you may say these are the areas which are localized. Then based on that, you may say that this is my etiology, and then you must do test. So you didn't do that anatomical localization. That's very important. At the end of detailed history and neurological exam, you have to give is it localizable to one particular area? Then if you say these are the multiple areas, then you must list down, these are the anatomical localization. Therefore, my differential diagnosis. Otherwise, it was very good. We have time for one question. Any questions? Guys? None? Other than that, you skipped the MRI findings and went to the CSF. Why did you do MRI before CSF?
To rule out, because the patient had features of raised ICP, to rule out any tumors or intracranial space occupying lesions, we usually...
In all meningitis, one must do MRI before CSF?
Not necessarily, but since this patient had a chronic meningitis and CNS tumors or space occupying lesions could not be excluded, we proceeded
meningitis
with an
by itself should not require an MRI. That's a waste of time. If you have focal neurological deficits and you have papilledema, then you are worried you must do. Otherwise, very often people waste time getting MRI, CT before doing a CSF. But you had got multiple neurological deficit and papilledema, so I suppose it's justified. But you left that finding for the end. You told us the finding and then gone on. Because does it angiostrongylosis cause multiple infarcts?
It does. It can.
Okay. There are no other questions. Medicine 3.